Good afternoon, everyone. You're very welcome to today's webinar, which is about COVID-19 vaccination. We appreciate that we are at the time where African governments are struggling to convince populations to go up for the COVID-19 vaccine. And we know that people have to take up to 3 shots. So there is a lot we need to know if this strategy is to prove useful for preventing COVID-19 in Africa. We are going to have 1.5 hours to enjoy this conversation. And I'll start off by summarizing a few housekeeping rules. One, if you wish to take the floor, I'll kindly request you to virtually raise your hand via the platform, and then I'll give you the floor. And when you have the floor, kindly keep your intervention short, up to about 1 minute, and that will help us to allow maximum participation. And then I also encourage you to post your questions or remarks via the Slido so that we can pick these up in advance and prepare for the Q&A session. And this Slido is going to remain until the end of the session. And now I'm delighted to introduce our panelist for the day, Dr. Andrew Mushugira. Dr. Andrew is a medical doctor, an infectious diseases specialist, and also a clinical epidemiologist. He's a graduate of Makerere University, University of London, and then University of Washington. So he's bringing a lot of diversity to this discussion. He's currently a senior research scientist at the prestigious Infectious Diseases Institute, Makerere University, with over 18 years experience in HIV research. And his experiences encompasses clinical trials, demonstration projects, implementation science, and also safety studies in Africa. And he's done some impressive and interesting work around pneumococcal and polycyclic vaccine in HIV-1 among adult HIV-infected adults. We are very delighted to have you, Andrew, this afternoon, and you have the floor.
Thank you very much, Eve, for the kind introduction. I am thankful for this opportunity to share about COVID-19 vaccination for people with pre-existing conditions. And in this talk, we are going to focus on HIV and NCDs. So by way of introduction, just to remind ourselves, as of today, we had about 142 million confirmed COVID cases. We all know that is an underestimate because the proportion that are being tested, for example, in Uganda, is very low. But what we see on the global map is a very high case burden, 142 million, and unfortunately, 3 million of our fellow human beings have left us. In the African continent, the pandemic is concentrated in South Africa, where we are familiar with the fact that they started vaccinating with AstraZeneca, and then they got the B1.351 or the South African variant, which in lab studies was not as effective, so they switched to the Johnson & Johnson vaccine, and as we all know, that has also been paused. So the country in Africa with the highest disease burden is also having challenges with vaccination. We see increasing incidence in Kenya and Ethiopia, as well as Nigeria, and coupled with North Africa, Egypt, Libya, Tunisia, Algeria, and Morocco. So high prevalence across the world. I want you to note what is going on in India, because COVAX, which supplies vaccines for the African continent, is supplied by the Serum Institute of India, and India has banned exports of vaccines because their own epidemic is exploding. Moving on to the global vaccination coverage, This is the largest ever vaccination campaign in history. As of today, more than 910 million vaccines had been administered, enough to cover 6% of the global population. In Africa, you can see that the highest coverage is in Morocco, and Senegal and Ghana are also doing well, as well as Equatorial Guinea and Rwanda. Zambia as well is doing well with vaccination, as well as Mauritius, so Seychelles in the Indian Ocean. Of concern here is Ethiopia, with high incidence, has barely done any vaccination. Kenya as well has used about, as we'll see later, about half the doses they've gotten from COVID. South Africa, where we have the highest incidence and prevalence, needs to vaccinate a higher proportion of its citizens in order to control the pandemic. The global picture is that of Israel as the world leader, very high coverage in Saudi Arabia, as expected in Western Europe, the United States, and North America in general, and then Chile as well in South America. By way of reminder, SARS-CoV-2 virus is mostly spread through droplet transmission when people cough, sneeze, laugh, sing, or cough in proximity with each other. And we know the points of entry, which are well summarized as MEN, M-E-N, mouth, eyes, and nose, and also by direct self-inoculation through direct contact with infected surfaces or fluids. So I think this is fairly familiar with us. We're also increasingly aware that risk factors for susceptibility for infection and risk factors for disease, the strongest predictor is really older age, because in the global north, most of the deaths are in people, about 65% of the deaths are in people older than 80. Our focus today is the comorbidities, non-communicable diseases, and HIV that also increase susceptibility and risk for severe disease. On the African continent, men and women get infected at similar rates, but men are 1.7 times more likely to suffer from severe disease on the African continent and to die from COVID. We're increasingly seeing the effect of genetics as variants of the virus circulate. We do know that we now have the South African variant B1.351 in Uganda, and as well as the P1 variant in Brazil and the B1.1.7 variant from the UK. In children, particularly cross-immunity with other adenoviruses can be protective. But at the bottom, I want us to focus on the inoculum, the amount of virus that one is exposed to when somebody infected coughs, sneezes, laughs, or sings. So focusing on the inoculum, the next slide summarizes the immune response to SARS-CoV-2. I would not go into the technical immunological details. I just want to focus on two things. When somebody breathes in the virus on the left, the green particles, either they inhale a low amount of virus, which is a low virus titer, or a large amount of virus, which is a high virus titer. We now know that the amount of virus one is exposed to determines the clinical course and the immune response. So people who take in low amounts of virus tend to have a mild infection, which can be managed at home in supportive care or in the hospital. They generate immune response and they generally recover. However, people who are exposed to a lot of virus, high amount of virus, tend to develop severe disease, which may end up in ICU with multiple lung injury, multiple organ injury, and unfortunately may result in death or recovery. The point of this slide being the importance of wearing masks, because masks decrease the amount of virus you're exposed to. So I find this a very helpful graphic to remember that wearing masks and keeping a physical distance are two very important things for preventing this disease. What are the risk factors for severe illness? I have listed a number of factors here that have been shown in multiple studies to be predictive of severe COVID-19. They include obesity and overweight, cancer, HIV, and diabetes. What jumps out at you at this slide are two things. The first is that risk factors are also non-communicable diseases, cancer, HIV, diabetes, chronic obstructive pulmonary disease, and chronic kidney disease, and also cerebrovascular disease. Those are the NCDs we already have. The second is factors like pregnancy and smoking. Those jump out at you, and modifiable risk factors like obesity. Factors that may cause severe illness include asthma, hypertension, immune deficiency, and liver disease. In some studies, these have been shown to predict severe illness, and in others, they have not. So the evidence is mixed, and that is why we call them possible risk factors. We're not yet sure whether they are predictive or not. As members of the African Palliative Care Alliance, you're very familiar with non-communicable diseases, the invisible epidemic of heart disease, stroke, cancer, diabetes, and chronic respiratory disease, the leading causes of death in the world. As many of you are aware, we are going through what we call epidemiologic transition, where in 1950 in Kampala, Uganda, where I am speaking from, there was virtually no heart disease among the African population. Heart disease was mostly concentrated in the Asian and European populations who ate more fatty food and were more sedentary. Africans mostly ate food that was boiled, they walked to work, they worked in their gardens, were physically active. Fast forward 50 years, and now we're starting to see heart disease in people younger than 50, something we never saw when we were training in the medical school a couple of decades ago. You're also familiar with the fact that 3/4 of global deaths are due to non-communicable diseases, and that non-communicable diseases, nearly half are premature deaths, i.e. before age 70. Importantly, most of the risk factors for non-communicable diseases are modifiable. These are preventable diseases. If only we led a healthy lifestyle, ate health food diets, were physically active, and avoided smoking and alcohol consumption. So the take-home point here is an invisible epidemic of non-communicable diseases on the African continent. And this is shown in this graphic, which shows us the prevalence of obesity globally. But focusing on the African continent, you can see that we have what you could call a bipolar distribution, concentrated in the north of Africa and also in South Africa. And the reasons for that are well described. And so when you look at Saudi Arabia, for example, that is a function of high obesity prevalence due to low physical activity and consumption of processed food. And you could say the same for Southern Africa as well as Egypt and Libya. In the middle of Africa is fairly low prevalence, but growing. So the continent is progressively growing heavier, including in East and Central Africa. We can see the same picture shown here with a concentration in the north of Africa, so Sudan, Egypt, Libya, and Algeria, Tunisia, and Morocco. So this time, not so much in Southern Africa, but also in North Africa. We can see prevalence also concentrated here in North Africa, particularly in Sudan and Egypt. So diabetes on the continent, but mostly concentrated in the north. However, when you look at the Democratic Republic of Congo in Central Africa, as well as Congo-Brazzaville, you can see that diabetes is pretty common also in Central Africa, as well as in Ethiopia and Somalia, not to mention Southern Africa. And layered on top of that epidemic of NCDs is our existing HIV pandemic, as you all know, concentrated in Southern and East Africa and not very prevalent in North Africa. So there's the point of all these graphics is to show a layer of epidemics, which is COVID-19, NCDs, and HIV, all on the African continent and all contributing to the burden of disease. So when we have these combinations of non-communicable diseases and COVID pandemic. What we are increasingly aware of is that people with non-communicable diseases, heart disease, stroke, cancer, and also have risk factors like obesity, have severe COVID-19 infections and are also more likely to die from COVID-19. So this is a story that we need to continue to document on the African continent. It is well described in the global north, but considering our unique situation on the continent where we have an added burden of HIV, it would be important to document these outcomes. Moving on to people with HIV, we do know that as people grow older, the number of comorbidities they have increases. This is work done in the United Kingdom among people with HIV older than 50. A survey of about 5,000 people, most of whom were on treatment and had a recent viral load measurement. As you can see in the text on the left, the comorbidities were common, especially in older age groups. The bar graphs on your right show the relationship between age and the number of comorbidities. And as people grow older, the number of comorbidities increases. So starting at age 50, nearly 40% have no comorbidity, and by age 70, that is decreased to about 18%. At age 50, nobody has more than 5 comorbidities, but by age 70, everybody has at least 6. So this shows that as we grow older, comorbidities become more common among people who live with HIV. Regarding patients with cancer, this is work done looking at the effect of the type of cancer people have and the age and the sex on prevalence of COVID-19 and the case fatality ratio, the number of people who have cases who die, number of patients who die in the UK. And we can see from the panel on your right that all-cause case fatality ratio in adults, death from any cause increases from about 1 in 10 for people aged between 40 and 49 to nearly 1 in 2 for those aged greater than 80. And importantly, among patients who have hematologic malignancies like leukemia, if they have severer disease and also are more likely to die. The reasons for this are complex. I won't go into them here, but one of them may be that leukemia interferes with immune function. So the take-home point here is older age is associated with higher mortality among people with COVID-19. Many conditions and treatments can cause someone to have a weakened immune system, including people with HIV who have a low CD4 count, or those who are not on treatment and have unsuppressed viral load, as well as other conditions. And it is thought that having a weakened immune system may increase the risk of severe illness. However, data shows that people with HIV who are virally suppressed are essentially have the same risk of COVID-19 as people who do not have HIV. And this is very good news for the continent with the highest burden of HIV in the world. So looking at this data, we have a small case series from Boston in which 36 had confirmed COVID and 11 had probable COVID. And what you see is that most of these were people who are non-white, and 85% had a comorbidity associated with severity. That's a very high proportion, underlying the strong connection between COVID-19 and comorbidities of non-communicable diseases. In the New York area, they compared people with HIV who had COVID-19 and those who did not have HIV and had COVID-19. And importantly, they found that there was no difference in the severity of disease when people were admitted or while they were in hospital when comparing people with HIV versus people without HIV. And this is very encouraging data that suggests that HIV does not seem to affect the severity or death from COVID-19. Further work done with people with HIV in the United States, nearly all of whom were on treatment and had a very high proportion with viral suppression. They looked at admission to the ICU, mechanical ventilation, or death. And what they did find is that people who are older, people who had chronic lung disease, people who had high blood pressure, and lower CD4 counts were less likely to survive. Lower CD4 counts are shown in the graph on your right, the green line at the bottom, that survival curve, where you see that at the beginning, at day 0, 100% were alive, and by day 35, only about 82% were still alive. They're showing that people with CD4 counts less than 200 less likely to survive compared with those with CD4 counts greater than 500. From a statistical point of view, this is not significantly different because the curves cross, but I'm not going to go into that. From the clinical point of view, we can see poorer survival at lower CD4 counts. So the study concluded there's no association between treatment or lack of viral suppression and COVID-19 outcomes, just because those curves cross. Now, there's a theoretical risk that has been recently discussed in the literature that I'll go through and hope it makes sense. I talked about Africa having the highest burden of HIV. And in 2007, the HIV Vaccine Trials Network conducted 2 large HIV vaccine studies. One was called STEP, and the other one was called PAMBILI, and PAMBILI was mostly based in South Africa. And what they did find, they eventually stopped the trials because the vaccine did not appear to work, the vaccine candidates that were tested. So the vaccine was what we call an adenovirus 5 viral vector. Viral vector is simply a messenger, an envelope in which you package the genetic material from HIV, which is harmless, of course, cannot multiply in the person. And so people are given this vaccine. And what they showed is that men who were positive for this virus we call adenovirus 5 and who are uncircumcised were more likely to get HIV, which is a very concerning finding. However, when they did another study in which they gave a DNA vaccine followed by an adenovirus 5 vector in a vaccine that did not contain HIV envelope, and in which the people who received the vaccine were negative for adenovirus 5, they did not find any increased risk of HIV. And so in 2013, the National Institutes of Health warned that for non-HIV vaccine trials using adenovirus 5 viral vectors in areas of high prevalence like Africa, this could cause increased HIV acquisition. Susan Buckbinder and colleagues just last year recommended that this issue should be studied now that we're using adenovirus 5 vector vaccines for SARS-CoV-2. This is a theoretical concern. It hasn't yet been shown to be important, but it's good to learn from history. And so in areas like the United States where they have mRNA vaccines or protein-based vaccines, people may choose to take those vaccines instead of those based on adenovirus 5 vaccines. So what do I mean by this? This is an overview of the technologies used in COVID vaccines. In the column on your left, under type of vaccine, you can see that we have different technologies, live attenuated, inactivated, and so on and so forth. But if you scroll down to the 5th row, viral vector vaccines, it explains what a viral vector vaccine does. And one of the vaccines that uses technology that is licensed is the Ebola vaccine that has recently been used in the Democratic Republic of Congo to control their recent Ebola outbreaks. So a number of COVID-19 vaccines use viral vector technology, including the AstraZeneca vaccine, but that one does not use the adenovirus 5 vector, which was associated with increased HIV risk. So of importance to Africa is that 2 current vaccines, the Russian Gamaleya Sputnik 5 and the CanSino vaccine from China, both use adenovirus 5 vectors. So there's a theoretical risk that if you use them in Africa, in areas with high HIV prevalence, and give them to HIV negative men, that they may be at increased risk of HIV. And again, I emphasize it's theoretical. So moving forward, when we look at the types of vaccines being used on the continent, you can see that the Russian Gamaleya vaccine is being used in Ghana and Libya. That is the orange Ghana, Libya, as well as the red, which is Algeria and Guinea, and also in the turquoise color, which is Congo Brazzaville. So 5 countries in Africa using the Gamaleya vaccine, which has an adenovirus 5 vector. One would argue that the countries in West Africa have low HIV prevalence, so theoretically, the only country we could worry about was maybe Congo Brazzaville. The other takeaway point from this slide is that South Africa is the only country on the continent that was using the Johnson & Johnson vaccine, which, as you know, the advantage of was being a single-dose vaccine. But given the recent concerns about clots and the pause in the United States, that has been stopped. So South Africa had previously chosen to use AstraZeneca, and that was stopped when their variant showed that that vaccine wasn't very effective. So like I said earlier, the country with the largest COVID burden is having an issue with which vaccine to use. The map on your right just shows that most countries in Africa are using the AstraZeneca vaccine, except notably South Africa and our friends in Tanzania. For Zimbabwe, you can see that they've chosen to use a combination of the Sinopharm and Sinovac vaccines from China and Covaxin from India. So they're not using any Western-made vaccines. So the take-home point for people living with HIV is that COVID-19 vaccines are safe. And the reason regulators believe they're safe is none of them contains a live virus. So you'd worry about a live virus multiplying into people who may have immune function challenges, but none of them have. So people living with HIV should take the vaccine when it's available. These vaccines bring the same benefits to people with HIV as those to people without HIV, which is essentially they prevent severe disease and they potentially reduce transmission. And so people with HIV should take their treatment, they should continue to remain virus suppressed, and they should be vaccinated against COVID-19. And even after vaccination, it doesn't mean we stop wearing masks or physically distancing, but we continue to take these preventive measures against the virus. Because somebody who is vaccinated may be protected from disease, but they may be unwittingly transmitting it to others, which is why we need to wear masks. And of course, the second reason is that now we have variants, and somebody may be infected with a variant which overcomes the existing immunity. How about cancer? Large burden of disease on the African continent. It's recommended that cancer patients are a priority group for cancer COVID vaccination. And for people who care like yourselves, for people who have cancer, you have competing risks of death. Death from COVID-19 versus death from cancer. And since people who have cancer have high disease burden and also death, it's important that they are vaccinated to protect them from a preventable death. It is thought that the immune response to vaccination may be a little less in people with cancer, but this does not stop us from offering vaccination to cancer patients. When we look at these recommendations from the National Comprehensive Cancer Network, we have 2 columns. The first is the treatment and type of cancer, and the second is a recommendation for vaccination. And if you focus in the column on your right, you can see that vaccination is recommended for all types of cancers and treatments, except essentially in 3 circumstances. The first is that if there's major surgery planned, that the date of surgery should be separated from the date of vaccination. This is because if a patient has a fever after operation, you wouldn't know whether the fever is from an infection or whether it is a side effect of the vaccine. So it helps to separate those 2. For patients who are receiving chemotherapy, for example, those with acute leukemia, it's recommended that you delay vaccination until the white cell count recovers. And then in those who are having transplants, to wait until at least 3 months after transplantation in order to vaccinate. I like the row at the bottom. It is very important to remember to vaccinate caregivers and household members of people with cancer to protect them as well. And so that's important, not just the people with cancer, but also their caregivers. Moving on to diabetes, we do know that COVID-19 is linked to severe diabetes outcomes that can, in their own right, lead to death. We now know that both type 1 and type 2 diabetes are increased risk of COVID. And for this reason, people with diabetes are also a priority for vaccination. People with cancer, with HIV, with diabetes cannot be vaccinated unless they have allergic reactions to COVID vaccinations, to COVID vaccines, I'm sorry. Moving on to cardiovascular disease, we do know that COVID-19 directly injures the heart, and it may increase the risk of bad outcomes uh, regarding heart disease. We also know that pre-existing heart disease is associated with higher risk of COVID-19. And so the recommendation that people who have heart disease or stroke should be vaccinated as soon as possible because they are at greater risk from the virus than they are from the vaccine. And this is a really important point that you should remember. You could forget all the stats and recommendations, but remember you're facing two competing risks, and you have risk from the virus and risk from the vaccine. And the risk from the vaccine is much, much, much lower than it is from the virus. Moving on to Uganda, where I'm speaking from, the picture on your right shows our National Referral Hospital in Malago and people queuing for COVID-19 vaccination. The vaccines rollout was started on the 10th of March. I was initially targeted to frontline healthcare workers, as well as priority populations, three buckets: people in teaching institutions, the military or security institutions, and also people in religious institutions. What jumps out here looking at the picture is how people have formed orderly queues, but they're not physically distancing, except a couple in the white coats. And it's just a sober reminder about how difficult it is to change human behavior when highly educated health workers forget sometimes that they need physically distance. Maybe because they're outside, they may feel like they're safer. So some of you may also know that the AstraZeneca vaccine has now been renamed to Vaxzevria, and it's called Covishield in India. Various efficacy estimates have been published depending on where the trials were done, but the most recent was 79% in a US study. The company plans to, or has submitted their data to the Food and Drug Administration, and they'll give us a final estimate then. We all know it's a two-dose vaccine that's been approved for use in Brazil. It's no longer used in Denmark because of the rare occurrence of blood clots, and is used on the African continent. It's been approved provisionally in these countries and used elsewhere under WHO guidance and the Africa Regulatory Task Force. So moving on to Uganda, vaccination beginning in the early March, slow uptake initially, and then as early adopters took it, and then eventually cranking up. Uganda has vaccinated about 230,000 people to date, which is about 0.5% of its population. So a long way to go. One of the reasons that uptake of vaccination has been slow is misinformation on social media and this negative messaging, especially coming from the global north, where we have a very well-funded and very well-organized anti-vaccine groups, is a key inhibitor to vaccine uptake. To quote our permanent Secretary of the Ministry of Health, there is lots of misinformation out there, and this negative messaging, especially in Europe and America, is the main reason our vaccinations took off to a slow start. Enthusiasm has been low because people are being told bad things about the vaccine. And this was yesterday's Wall Street Journal report. Speaking of misinformation, it was announced in the news that Malawi was going to destroy 16,000 AstraZeneca doses as people declined to be vaccinated because of rumors about vaccines and out-of-date injections. And so vaccine hesitance is a real problem on our continent, and it's something that we have to strategically address. It has been encouraging to see African leaders getting vaccinated in public, together with their spouses and key opinion leaders as well, including religious and cultural leaders. And more of this needs to be done to overcome the fears of the late majority and those who may be unwilling to be vaccinated because of what they've read or seen or heard from others. On the first slide, I showed you that the COVID epidemic is exploding in India, and India had started restricting vaccine exports from the Serum Institute because they wanted to prioritize production for local consumption. So COVAX is expecting that they will have 90 million fewer doses by May that they'll be able to ship out to beneficiary countries. And so to quote the head of the Africa CDC, we are in a bind as a continent. We cannot predict when second doses will come, and that is not good for our vaccination program. However, the Africa CDC and the WHO are working closely with the Serum Institute in India to ensure that what was contractually agreed is supplied. But this just shows you how this pandemic can be so predictable and is subject to factors outside the control of those who are doing vaccination. This graphic shows how vaccines administered have been utilized across the continent, with a very high utilization in Botswana, Seychelles, and Eswatini, and followed by Morocco. So really impressive that all the doses delivered have been administered. Performance gradually declines. For the countries that are heavily hit on the continent, I talked about Kenya with 57% utilization, and Malawi, where vaccines were being discarded at 48%, Uganda at 22% of vaccines delivered. But of concern for me is two countries with high incidence on the continent. One is Algeria, and the other one is Ethiopia, as we showed you on the map on the first slide. And as you can see, utilization is really, really poor. And these countries need to scale up vaccine coverage in order to control the epidemics. Importantly, here on this graph as well, is South Africa had only managed to give about 1 in 3 doses administered, and they have the worst epidemic on the continent. So South Africa also needs to crank up vaccine coverage. Moving on back to Uganda, where we are using a multi-phased approach, starting, as I said, with frontline healthcare workers and critical services, and then moving in the second phase to people with comorbidities, as we had been discussing and is the focus of this webinar. People with comorbidities will be in phase 2, and then phase 3 will follow after that. So again, the importance of vaccinating people with comorbidities. So in summary, COVID-19 vaccines are the most promising approach for controlling the global pandemic. We have shown the evidence and discussed extensively why comorbidities are important. They're associated with severe illness and death. And we have an ongoing epidemic of non-communicable disease on the continent, many of whose risk factors are modifiable, and this disease is preventable. But that will require very serious changes in lifestyle and behavior, which, as we know, is not easy to do. All people who have comorbidities, including HIV and non-communicable diseases, are eligible to be vaccinated unless they have severe or immediate allergic reactions to COVID vaccines. And as we've spoken about, there's a very, very rare risk of about 1 in a million when dealing with adenovirus 26-based vaccines, which are AstraZeneca or Vaxzevria, and the Johnson & Johnson vaccine. And that the jury is still out on that one, but the WHO has recommended that African countries continue using the AstraZeneca or Vaxzevria vaccine, which is the most widely used vaccine on our continent. Excuse me. So the take-home message for me is that for people with comorbidities, the risk from virus is much greater than risk from vaccine. Vaccine adverse effects are very well known. It's mostly mild side effects which last up to 2 days, fever, headache, fatigue, and pain at the site of the injection. So when you're weighing and you have a weighing scale, the weighing scale will shift much more to the side of the virus than it will from the vaccine. And the second take-home message for me is that a stick which is far away does not kill the snake. I have heard people saying that they will wait for better vaccines, or they'll wait until the Pfizer or Moderna vaccines come, and they do not want to utilize the vaccines that are currently available. And I think from our African wisdom, this is a proverb from northern Uganda, we do know that you use what you have in the house to solve your problem. You don't have to wait for something that may be far away in the bush because it may not solve your problem. So to summarize, let us use the tools we have to solve the problem that we have. And with that, I thank you for your attention and thank you for the opportunity to share this information.
Thank you very much, Andrew, for that excellent presentation. And I can see there are lots of take-home messages for us in the palliative care fraternity. And also the presentation answers most of our pressing questions as palliative care providers. Ladies and gentlemen, now I'm opening up the floor for questions. Miss Lillian Lewa, your hand has been up for a while. I give you the floor to pose your question. Lillian? Mabel, your hand was up. Do you have a question? Lillian, you're muted. Please unmute yourself and ask your question. Okay, Dr. Zippy, do you have a question for Dr. Andrew? Okay, we have a thank you note from Dr. Moira. And then I'm going to pose my question to you, Dr. Andrew. Our clients commonly ask the benefit of taking the vaccine because you still have to keep your mask on, you still have to social distance, and you cannot go back to our old life. You must live in the new normal. So why should they take the vaccine?
That's a very good question and something that people are asking. What is the whole point then of being vaccinated? The point of being vaccinated is that it protects you from severe illness and death. And for many of the studies, the protection against severe illness and death is actually quite high, higher than the published efficacy. In some studies, AstraZeneca vaccine is 100% protection against severe illness and death. So the point about masks has been complicated by variants. And also because many of the trials were not designed to answer the question of transmission, they're designed to answer the question of illness and death. Because you want to prevent hospitals from being overloaded, health systems from being overloaded. And so the way I summarize it is this: the golden rule is do unto others as you'd have them do unto you. Love your neighbor as yourself. So once you're vaccinated, you are protected. But you may get a mild infection that you may not know, and you may transmit it to others. And so for the sake of others, wear your mask and physically distance. The new normal is something that we are just going to have to get used to. Hopefully in the future, we may go back to the old normal, but I don't think that will happen because some things have changed. I may not go back to what we used to do, like working from the office. I think one good thing about the new normal is working from wherever you are, yeah, and having virtual meetings instead of having to fly to all over the world to attend meetings. Yeah. For some people, that is good, like spouses at home. For those who like traveling, maybe that is bad because there's less per diem. But I think the summary is love your neighbors yourself, protect others. So if in a village, everybody locks their house, they are protecting themselves. But also if everybody has a fence around their home, then you can prevent thieves from coming into the village. So we have to think individually and you also have to think communally at the same time, because COVID has taught us that we are all, if one is infected, we're all affected. I hope that answers the question. I was going to say that as host, you can unmute people. You have that authority, I think.
Okay. ICT, you could help me unmute Lillian. Her hand is up. I think she has a question, but maybe she
So
cannot.
if you hover over her name, I don't have that authority. You see three dots, and if you click on that, it should say unmute.
Okay. Lillian, I hope you can now pose your question when you're ready. And then we have another question from Lassie. She thanks you for the excellent overview and important information, and makes this note that some people say they do not want to put something foreign into their body, and this is why they refuse the vaccine. What would you say to such people to convince them to take the vaccine?
Thank you, Lacey, for that comment. It's very understandable that people would be suspicious of something new and something they would consider foreign. When a new disease comes, it's can come with a lot of fear and mistrust and suspicion and rumors. We've seen it for HIV, we've seen it for Ebola, we saw it for SARS and MERS and all the epidemics that have come, swine flu. There's always a fear of the unknown. As somebody who has been vaccinated myself, and somebody who has lost a mother-in-law to COVID, and has personally nursed my own daughter who got COVID from a visitor to our home, I know how scary it can be when COVID is in your face. And so for me, the reason to vaccinate is that we have a killer disease that has taken 3 million people already, and that many of us with our comorbidities and older age at risk for. And so when I vaccinate myself, I'm protecting myself, but I'm also protecting my loved ones. And so to me, I see that as a dual benefit. The vaccines have been tested in hundreds of thousands of people and have now been administered to 910 million people with very, very few side effects. The number of people who have gotten the clots published so far is 7 in the United States and 222 in the European Union. And so that is 230 people out of 910 million. So that shows you how safe the vaccines are. They've been intensively tested, they're continually monitored, and people should not fear to put something quote unquote foreign. Because we do that all the time. We eat new things, we taste new things, we breathe in all manner of things into as we're out there, all manner of pollutants, and our bodies can handle them. And so the vaccines are safe and effective and are recommended for us. Thank you.
Excellent. And then I have another question for you, Dr. Andrew. I know we need about 3 doses. So does the 1 or 2 doses give me some benefit of safety, or it's until you have the 3 doses?
That's a good question. So until a couple of weeks ago, South Africa, for example, is using the Johnson & Johnson vaccine, which is a single dose. And for most of these vaccines, protection kicks in after about 2 weeks. The other vaccines that we're using on the continent, which is the Sputnik 5, the AstraZeneca Vaxzevria, the CanSino, and the Sinopharm, all require 2 doses. And the duration of dosing is determined by the country. But in general, you have to wait until the second dose. Until 2 weeks after the second dose, consider yourself fully protected. But even as we've already discussed, you still need to observe precautions for the sake of others. But at least you can see in Israel, a country that has vaccinated more of its population than any other, there are about 60% of the population is vaccinated. We can see that life is returning to normal. People are going back to shop on holidays, they're traveling. And so that's an example of what life could be like if more of us got vaccinated. Schools reopening, synagogues reopening, and that is possible. We're going to see it in the United States as vaccines coverage is increasing, that life is quote unquote returning to normal.
Thank you very much for that Excellent response. And then another question is about how prepared Uganda is to roll out this vaccination effectively up to the most remote or hard to reach areas and maintain that complex cold chain requirement for the system.
That's an excellent point. I think the asker, is that correct English? The person asking the question is familiar with the Ugandan healthcare system and its challenges. I do know that Uganda has run a UNEPI program, expanded program organization, since the early 1980s, and it's been able to vaccinate children across the country. And if we just use the same systems for COVID vaccination, that would help. One of the reasons we chose AstraZeneca is that it can be stored at between 2 and 8 degrees in our normal fridges for vaccination. There will be challenges. The rollout has not been straightforward. People have gone to clinics and been turned away. Or sometimes you would go and they tell you, before we can open a vial, which has what, 5 or 6 doses, you need to go and bring 5 or 6 more people, because if we vaccinate you, then the rest of the doses will be spoiled. We can certainly improve the system and we can iron out the kinks. The task force of the Minister of Health is looking at lessons learned to try and improve it. So we did this for HIV. I can recall very clearly being at conferences that people said, Africa will not be able to roll out treatment because of all the challenges you have. And we have been able to do that. We're able to overcome Ebola, and I'm convinced that we can overcome COVID-19.
Thank you. I have another interesting question from Damaris. There is a myth related to the COVID-19 vaccine about being infertile after vaccination. Is this true? Does it affect one's fertility in any way?
Damaris has asked an excellent question. I think Damaris remembers about 7, 8 years ago in Kenya, there was a controversy about tetanus vaccination at the Catholic Bishops' Conference. And that was a huge, huge spat between the church and the Ministry of Health. And eventually what was concluded was that tetanus vaccination did not affect fertility of women. But that really damaged confidence in vaccines. And this myth about vaccines and infertility just doesn't apply to COVID-19. As I've just showed you, it also applies to other vaccines, as you saw in Kenya, in about, if I recall correctly, 2013, 2014. So COVID vaccines do not affect fertility. They have absolutely no connection with the ovaries, the fallopian tubes, the uterus, or the seminal vesicles, or any part of the male or female reproductive system. These are myths that are propagated to scare people. Put it this way, when the Pfizer trial was done, because that was one of the first to be completed, there are some people who got pregnant after being vaccinated and have since delivered healthy babies. So we already know that people who are vaccinated have no issues in fertility. But let's even expand it wider. We have vaccinated 910 million people across the world. Half of the world's population is women. So let's just give a rough guess of 400 million or 450 million. If the vaccine affected infertility, it would be front page news immediately because there's so much scrutiny about this vaccine. But at this point, people are delivering, people are conceiving, and there's no concern about fertility. The second concern is what about pregnancy? I did not talk about pregnancy because it's not an NCD, but women who are pregnant at higher risk of COVID, severe illness, and death, and adverse pregnancy outcomes. So women who are pregnant, it's recommended that they be vaccinated. We don't have a lot of safety data in pregnancy because, as you know, when we start clinical trials, we exclude pregnant women, but that research is now ongoing. But from those who got pregnant without knowing, we can already tell that it is safe. And then lastly, what about breastfeeding? I know there's concern about what will it affect the baby. The good news is that what we're finding is that there are COVID antibodies in the breast milk. And so by breastfeeding, a mom is also protecting her baby. So that is what we know so far. The data are limited, but what we can see so far is good. But I always believe in natural experiments because the ones we do are controlled. But the global national experiment of 900 million vaccines tells us there are no concerns about fertility.
Thank you very much, Dr. Andrew. Damaris, I hope that answers your question. And then we have another question from Lillian. Suppose you get the first dose, but due to unavoidable circumstances, you get the second dose after 1 month. Will the first dose still be effective?
It depends on what vaccine you are talking about. But let's assume that you're in Africa and most of us are going to be given the Vaxzevria vaccine or the AstraZeneca vaccine. For this vaccine, the dosing is anywhere between 4 and 12 weeks. Some countries do 4 weeks, some countries do 8 weeks like Uganda, and others actually do 12 weeks. And data presented recently shows that efficacy is actually even higher after if you wait 12 weeks. So getting vaccinated after the 1 month, for at least for AstraZeneca, is fine because the interval is 4 to 12 weeks, depending on how the trials were designed. So that is not an issue, at least for AstraZeneca.
And then there are concerns that the efficacy for this vaccine was reportedly about 65%. And people are suspicious that manufacturers commonly underrate the efficacy, but the actual efficacy in normal life might be grossly under the 65%. So what is the actual benefit of taking a vaccine which has very low efficacy scores?
Great question. So I'll give a two-part answer. The first is that manufacturers can cook the data if they want, but this data is heavily scrutinized by regulatory authorities. And you can already see for what happened with AstraZeneca last month when they did announce results from a US trial, and then they were called out by the National Institute of Allergy and Infectious Diseases, and they had to revise their estimate. So these data are heavily scrutinized by independent experts who look at it and do an independent review. I have been through an FDA audit, the Food and Drug Administration audit. They sent their own inspectors. They went through our data. They came down to Tororo in eastern Uganda and Kisumu in western Kenya. And they looked at the original patient charts themselves. They did not buy what we told them. They reviewed the data independently, and they came to their own conclusions that the results we reported were accurate. So that is the first part of the answer, independent oversight. The second part of the answer is that actually we've been so lucky with COVID that the results actually are working better in real life than they did in the clinical trials. And that as many, many people, for example, look at Israel. They did an analysis of their data after 1.8 million people had been vaccinated. So one of the reasons Israel has been very successful in vaccinating is that they made a deal with Pfizer. You give us vaccine doses and we shall give you data from our population. So scratch my back, I scratch yours. So we have this huge data set beyond the initial trials. And they found that 1.8 million vaccinated, 222 hospitalized, 23 deaths, and 0.7% reinfected. You can't beat that. That is a huge natural trial for a vaccine, and you can see how well it does. For the AstraZeneca vaccine, as you said, is 62%. The data that has come out post the trials shows almost 100% protection against severe illness and death. So you can distrust the manufacturer, but then the world is a great teacher, life is a great teacher, and the real world tells us that actually what they're telling us is true.
And another interesting question, there are a lot of concerns about the quality of healthcare services in Uganda and what is going to happen to individuals who experience severe adverse events, which they are hearing about in other countries. Do we have the capacity to meet their health needs?
That's a very important point, and it's an issue of concern for us as a country that we need to be prepared for these surprises. I have spent nearly 3 decades in research, and if there's one thing that is guaranteed, it is surprises. One of the surprises we had is this reports of rare blood clots in women and also low platelet counts. So Uganda has its challenges, but what we do know is that these allergic reactions are very rare. I haven't looked at the reports from the National Drug Authority, so I cannot authoritatively tell you how many people have had allergic reactions in the population. But let's assume that the odds of getting a blood clot are 1 in a million. So if you vaccinated the whole country with AstraZeneca, you would expect to see less than 45 cases of blood clots. The background rate, so the naturally occurring rate of blood clots in Uganda is way higher than 45, the number. And so I would happily vaccinate the whole country to manage the 45 cases. You have to do a public awareness campaign to tell people what warning signs to look out for, unexpected headaches, blurred vision, belly pain, or for allergic reactions. We do have adrenaline, or should have in most of our health facilities, to be able to manage these allergic reactions. So our health system is not perfect. It has a lot of catching up to do, but from a population-based perspective, the risk of these clots is very rare. I was telling somebody that you're more likely to get a blood clot after falling off a boda, motorcycle taxi, and getting a fracture and being immobilized in bed than you are from getting it from vaccination.
Thank you. That's very good news. And we have another question here. How much investment is going into developing the evidence base for use of vaccines in patients with non-communicable diseases?
So as I
Besides,
present,
please go ahead.
you are saying besides?
Yeah, please go ahead.
I was saying, as you presented, there's a lot of data that's been generated, mostly from China, where the epidemic started, and from Europe and North America. In Uganda, in Sub-Saharan Africa, most of our population is young and therefore doesn't have comorbidities. But in the Northern Africa and Southern Africa, where they have older populations, those data are being generated as we speak. There is so much research going on generated about COVID that it's hard to keep up. I did a search yesterday because somebody was asking me why, there's been, let me divert a bit here. There's been a lot of noise on social media about ivermectin, which is an antiparasitic drug, and why is it not being used to treat COVID-19? It reminds me of last July when hydroxychloroquine was the latest and the greatest drug. And what we did find is that we did the clinical trials and found that hydroxychloroquine did not work. Therefore, we stopped using it. Ivermectin, there are 65 clinical trials evaluating ivermectin and COVID, 65. There are 90 clinical trials looking at COVID-19 and vitamin D to treat COVID-19. There is a lot of research. You can't keep up with it. So for me, the issue with COVID is not a lack of research. The research is there. It is where you choose to get your information from. If you want the solid research, there's plenty of that. You cannot consume it all. But when it comes to social media and online misinformation, there's also a lot of that. And each side can convince you that they are right. So it's up to the listener to choose. Are you going to listen to this person who has backed up data from hundreds of millions of people? Or are you going to listen to somebody recording a video in their house telling you stuff or their personal opinion? And that is a challenge of our age. The WHO says vaccine hesitancy is one of the top 10 global health threats. And that was before COVID. It's even more severe now with COVID.
Okay. Thank you very much. And we have another question here from Irene. How about people with autoimmune diseases? Do you recommend vaccination?
These are really, really excellent questions. For people with autoimmune diseases, the recommendation is that you consult with your doctor. For example, the American Society of Rheumatology recommends that people getting a monoclonal antibody called Lumixitab, I hope I pronounced it correctly, may hold off getting vaccinated if they're an active treatment. So in those exceptions, we can choose to vaccinate on a case-by-case basis.
Okay. And then if I have contracted severe COVID and I decide to repent and take the vaccine, are there any benefits whatsoever at that stage?
That's a great question. Why should I be vaccinated if I've already had COVID? So we do know that you get naturally acquired immunity. So there are two ways to get immunity, either through natural infection, which is very risky because you might die or get long-term complications, or through vaccination. Vaccination is the fastest, cheapest, safest way of getting immunity. So if you've already had COVID, what we're finding is that if you wait at least 3 months, that's the CDC recommendation after severe COVID, and you vaccinate, the immune response I generate is even stronger than that from just vaccination alone. So for people who've had COVID, you're going to be even more protected if you vaccinate. The most high-profile case is the former president of the United States. He got COVID, was hospitalized, given novel treatments, and recovered. I think this was in December. And then in January, before he left the office, he got vaccinated. So that shows you the benefit of getting vaccinated, even if you've had COVID, and even if you're the president of the United States, because it is good for you and good for those around you.
Yes, thank you for that response. I hope nobody is putting up their hand. I've been taking questions off the Slido.
I'll just jump in here and say it is normal to have questions and concerns about vaccination. And I'm really glad that people are asking questions and that we'll do our best to answer them as best you can. But there are many online resources. The WHO has a wonderful web page where there are myths about COVID-19. There's a lot of vaccine information. So does the CDC. That's a great resource. So if I could go biblical here, the Bible tells us to, in 2 Timothy chapter 2, verse 15, to study to show yourself approved, a workman who is not ashamed, rightly dividing the word of truth. So I believe in reading and informing myself, not just going by so-and-so said, or I heard, but you look at the data, study for yourself, look at people who've been vaccinated, ask them what the experience was. Many of us I had no effects completely apart from a sore arm. Ask them, talk to them, don't just follow what you see on social media, because social media is mostly people's opinions. But study for yourself and be convinced in your own mind that what you're doing is safe and for the benefit of your family. We do know that there's a theory we call theory of diffusion of innovation. So whenever anything new comes out, there are people who will jump on it first. There are people who queue up the night before to buy a new iPhone, or when a new artist is in town, people will go and queue the day before and sleep outside the stadium or the room. Then there are early adopters. And then there are the late adopters, people who sit on the fence and say, let me see what happened to Dr. Eve. She got her first dose, she's fine. She got her second dose, she's fine. Nothing happened. My friend Penina got vaccinated, now she's pregnant. Oh, it doesn't stop fertility. There are people who will be like that. And then there'll be the die-hard conservatives who will resist and will be taken kicking and screaming to be vaccinated. That is just normal life. Some people adopt things early, some adopt things late, but it's important to be convinced and read for yourself. Don't just follow rumors.
Thank you very much, Dr. Andrew. Unfortunately, a few of us have the skills you have, so we tend to rely on people who give information in friendly formats, the bloggers and the people on social media.
Right.
Dr. Manuel, I'll kindly invite you to give us the last remarks. Dr. Emmanuel?
Thank you very much, Eve. I want to take this opportunity, first of all, to thank you, Andrew, for giving us this rich presentation of what we are facing as health workers and as APCA and as a network of service providers across Africa, and also for helping us unravel all those questions that are so common in our daily life. We want to thank you for focusing on the areas where we deal most with people who have HIV and non-communicable diseases. And I believe that this will go a long way in not only in helping us to look after ourselves, but also to look after others better and share the right information as we interact with our patients and their families and other health workers. Thank you very much for honoring our invitation. I also want to take the opportunity to thank Eva for moderating the session and Wezrai for organizing it. Thank you very much, and we wish you the best in life.
We should get vaccinated. Thank you very much, Dr. Andrew. We are profoundly grateful for your generosity. And thank you everyone for attending this session. Please get vaccinated and encourage colleagues and family members to get vaccinated. Thank you.
Thank you for having me.
Thank you.